Pneumonia. The radiological feature of infective pneumonia is consolidation. In lobar pneumonia, there is a uniform opacity of a lobe or segment without any displacement of the neighboring structures like fissures, diaphragm or trachea. Note the uniform opacity restricted to a single segment. This X-ray shows a uniform opacity of the right lower zone. The opacity merges with the heart shadow, hiding the heart border, indicating that it is in the right middle lobe. Note that it is bounded above by the transverse fissure, which is in its normal location. There is no displacement of the diaphragm or the mediastinum as would occur in a collapse. This is a consolidation of the right middle lobe due to lobar pneumonia. This is an X-ray of the left lower lobe consolidation. Note the uniform opacity of the left lower zone. The heart border is seen. It does not silhouette with the opacity, indicating that the consolidation is in the right lower lobe. There is no displacement of the mediastinum, so this is a consolidation of the right lower lobe due to lobar pneumonia. This is a close-up view of the left lower lobe consolidation, showing a very important radiological sign, that is air bronchogram. The arrows show the bronchi as radiolucent streaks contrasted against the opacity. Normally, the bronchi are not visible on plain X-ray of the chest, but in consolidation, when the surrounding alveoli are filled with fluid and become opaque, the bronchi become visible due to presence of air in them. This sign of air bronchogram is diagnostic for pneumonic consolidation. One must also know about the silhouette sign to be able to identify the lobe affected. Silhouette sign states that if two structures having similar radiographic densities are in contact with each other, that is at the same depth, then the interface between them is obliterated. But if they are at different depths, then they are seen as separate structures with their borders. In this consolidation of left lower lobe, the lesion could be in the lingular lobe anteriorly or in the lower lobe posteriorly. The heart border is indistinguishable, that is, silhouette sign is positive. The heart border in this area is an anterior structure, so the consolidation is anterior, that is, in the lingular lobe. While in this consolidation, the heart border is not obliterated, that is, a negative silhouette sign. So the consolidation is posterior, that is, in the left lower lobe. Applying this principle of the silhouette sign, if a consolidation of the left upper lobe obliterates the aortic knuckle, which is a posterior structure, then it is in the apico-posterior segment. If it does not obliterate it, then it is in the apico-anterior segment. The left heart border is anterior. So if a consolidation obliterates it, it is in the lingular lobe. If not, then it is in the lower lobe. The right heart border is also anterior. So if a consolidation obliterates it, it is in the right middle lobe. If not, it is in the right lower lobe. The domes of the diaphragm are in contact with the lower lobe. So if a consolidation obliterates it, it is in the lower lobe. Otherwise, it's in the middle or lingular lobe. This X-ray shows consolidation at two places. Firstly, in the right upper lobe, affecting the apico-anterior segment, and in the left lower lobe. In close-up view, note the uniform opacity characteristic of consolidation and the sharp delineation of the apical anterior segment lined by the transverse fissure below. The left lower lobe consolidation in close-up view shows a negative silhouette sign, that is, the heart border is clearly seen and the diaphragm is silhouetted, indicating affection of the lower lobe. Just next to the heart border, you can see a faint air bronchogram. This X-ray shows consolidation of the left apico-posterior segment. Note the uniform opacity and segmental distribution. It would be proper to remember here that this is the segment of the lung which is most commonly affected in tuberculous infections, and it mainly lies behind the clavicle laterally. In bacterial pneumonias, as the patient improves with treatment, the consolidation becomes progressively less opaque and resolves over 3 to 6 weeks. This X-ray shows a consolidation of right lower lobe, and the next X-ray repeated after 20 days shows a complete resolution. It is very important to repeat the X-ray every 1 or 2 weeks till complete resolution occurs. This is to look for two important pathologies. Number 1, development of a lung abscess, empyema or effusion. Note this partially resolved consolidation showing a air fluid level typical of a lung abscess. And number 2, if resolution is partial, there may be an underlying bronchogenic carcinoma with partial obstruction of the proximal bronchus. Note this dense hilar opacity in this partially resolved left lower lobe consolidation. Particularly, if there is a collapse associated with consolidation, bronchoscopy must be done to rule out bronchogenic carcinoma. Note again the uniform opacity of the lower lobe and dense opacity at the hilum. While evaluating consolidation, certain artifacts must be considered. Note the uniform opacity in the left lower zone. If you observe closely, a similar less dense opacity is seen on the left side. This is a soft tissue shadow of the breast. So the radiological features of consolidation due to infective pneumonias are a uniform dense white opacity affecting a single anatomical lobe or segment. It may show an air bronchogram if bronchi are patent, and silhouette sign with the borders of the mediastinum. It would be appropriate here to revise the anatomical representation of the lobes of the lung on a plain X-ray of the chest as seen in lobar pneumonia. On the right side, this is the upper lobe above the transverse fissure. This is the middle lobe merging with the heart border but not with the diaphragm. And this is the lower lobe merging with the diaphragm but not with the heart border. On the left side, this is the upper lobe. Its posterior segment silhouettes with the aortic knuckle. This is the lingular lobe merging with the heart border. And this is the lower lobe merging with the diaphragm but not with the heart border. Also, let us compare and note the difference between consolidation and infiltration. On the left is a patch of consolidation which shows a uniform white opacity limited to a single lung segment, while on the right is the typical infiltration showing a cotton wool like fluffy nature not restricted to any particular segment. In a close-up view, note the uniform white opacity of consolidation and the irregular patchy opacity of infiltration. That is the difference between consolidation and infiltration.
For more such stuff, do subscribe to Date with Medicine.